Good morning, everyone, and welcome to our webinar broadcasted here from Oberrat, close to Cologne in Germany. My name is Matthias Geuter. I'm head of marketing here at Spiegel & Theis Medizintechnik, and it's my pleasure of hosting today's webinar. As you all know, the title of today's webinar is Transcanal Endoscopic Ear Surgery, an approach that's about to become state-of-the-art in modern medical theaters. This also explains the great response that we have received so far. We have more than 1,500 registrations from all over the world, people that are interested in this technique. So we have people dialed in from Australia, Austria, Belgium, Chile, Denmark, so all the way over to the east to Russia. So in other words, we actually should have said good morning, good day, as well as good evening. What I like about this, it's really great to see so many specialists within the ENT community that show interest in this great surgical approach. So let me introduce to you very quickly our great speakers that will share years of experience on this topic. We all know Professor Panetti. He will talk about transcanal endoscopic ear surgery in general, using specialist and specific instruments. Our second speaker would have been Professor Prasuti. Unfortunately, he will not be able to join us today because of an unexpected emergency that he could not postpone. But luckily, our third speaker, Dr. Bonali, who works close together with Professor Prasuti, he will take over his presentation that talks about instruments that he uses for endoscopic otoneurosurgery. Last but not least, we have our third speaker, as already mentioned, Dr. Bonali, who will share his experience about electrosurgical devices in endoscopic ear surgery. All right. Just before we start and hand over to Professor Prasuti, there are a few things I would like to explain to you. You can ask questions throughout the webinar by using the YouTube live chat option that you will find at the bottom right side on your screen. But of course, that only works if you have your Gmail account and if you're logged onto our YouTube channel. If you do not have a Gmail account, please use our email address and send your emails to export@spiegel-theis.com. All questions will then be collected and addressed in the very end after the third speech. So if we do not have enough time afterwards, we will send you all answered questions in a written version through our distributors once we get all the feedback from our speakers. Last but not least, at the end, after the webinar, we will send you a questionnaire online. You will receive an email from Spiegel & Theis Medizintechnik asking you for your feedback. This is very, very important for us to get your feedback, so that will help us to improve our future webinars. So already, thank you for taking your time for filling out and complete those questionnaires and send those back to us. All right, I guess you're all excited listening to Professor Panetti, our first presentation. I'm all excited to see what he has to say. And I would love at this point to hand over to Professor Panetti. So I hope he's ready to take over from here. Good morning.
Good morning. Good morning. And I thank you for the presentation. And I begin my presentation. I'm sorry for my bad English. This presentation, I'm going to discuss about the basic instrument and useful device in endoscopic ear surgery. During the last decades, the rise of transcanal endoscopic ear surgery, TEES, has led to a drastic increase to perform stapedoplasty, tympanoplastics, cholecystoma surgery, and various middle ear and inner ear disease. The growth of interest in transcanal endoscopic ear surgery as part to creation and adaptation of new endoscopes and endoscopic instrumentation designed in order to facilitate the kind of surgery. The approach to middle ear surgery can be totally endoscopic. Now, for a few minutes that explain the various devices.
Everybody, surgeon usually at the head of the patients on the side of the ear to be operated. Some surgeons prefer to stay standing up on their feet, but we think that it's very useful to have a chair to be sit and to have a support for the forearm, as in the image that we are showing. Moreover, endoscopic column should be always at the maximum surgeon and monitor at the same height of his eyes in order to prevent neck pain. In some cases, for example, when a sinus tympani is very deep, as in the CT to store videos and image. Obviously, Gabriella, mi sa che si è bloccata un attimo, facciamo share screen. Sì. Che devo cliccare? Questa.
No, no, qua.
La presentazione.
Vabbè, ok. Metti share.
Okay. In our experience, also microscope is an essential component of operating room setting. It should be always prepared in a sterile way in case of need and to integrate the endoscopic procedures. For this reason, every otosurgeon should be always able to convert endoscopic approach to microscopic one and vice versa. This is an image of a basic surgical instrumentation we usually use, in which are represented classic instruments for ear surgery and the special kit panetti for the suction and for endoscopic approach. You know that among main limitations of endoscopic technique, there is the use of a single hand and the frequent fogging of the tip of the optic ask for a frequent wash of operatory field and a frequent need of suction of liquids and blood. So, in order to minimize the pitfall related with the bleeding control, we find some tools to be very useful. And in the specific, molecular resonance scalpel, bone surgery devices, and suction instruments are these as concern without reaching high temperatures. In this way, we can harvest tympanomeatal flap without creating damage to. Moreover, it is also useful for dissection of cholecystoma from ossicle chain and from epitympanum, as we after will show. About bone surgery devices, we can say that in the cutting, the bar for excuse me, for drilling instruments for endoscopic approach are characterized to have protected bars. Drilling instrument for and they are useful for microscopic surgery, but not for endoscopic. Now I will give back word to my Professor Panetti.
Okay, thank you for your presentation. Before speaking about suction instrument, I would like to show you a video about my first experience. In this time, in 2009, I operated with a microscopic approach, a second look of open tympanoplasty. As you can see, with I said 45 degree the 4 millimeter of diameter that I used for the sinus surgery to see better the hidden areas. The troubles to remove skin I'm sorry for the connection.
Yeah, the connection is not very best. You just froze for about a minute, so maybe you want to repeat that.
Oh, it's good.
No, we can't hear anything.
Yeah, instable.
Oh no, it's better.
Now it's better.
It is a little static.
Okay. As I asked at first, the first result were very encouraging, and so I decided to meet Dr. Charles Strout, Chief Engineer of Spiegel and Tice. That then we actually realized that the instrument that you can see today, and also became good friends. I take the chance to send regards to him and thank you for it. I, Charles. Okay, 89 years ago, we decided to develop an instrumentary provided with suction channel produce the same characteristics of a traditional instrumentary or autosurgery that the surgeon is already familiar with. As you can see, the set is composed by instrument provided with suction channel with shape and length similar to the traditional autosurgical instrumentary. This instrument has two important key points. I show a little video that show the two important key points. Okay, this is a vision of the instrumentary. The first key point is the 70 degrees angle adapter in this short video this point. Okay, there is no friction, no weight. The second is the possibility of a 600-degree rotation, which remove any friction, as you can see very well. Another goal to achieve has been the easy and quick interchangeability of the instrument. For this reason, each instrument is provided with a lure lock joint that is complementary to the connector. So you can quickly change the instrument during the surgery. Another important point is the possibility to clean very well the instrument after surgery with the special system that you can see in this slide. Okay. The set of instruments include also knife of a different shape and size, which are used to call in a simple mode. As you can see in this slide, we are labeled in our operating room the sickle knife like knife number 1, circular scalpel knife number 2A, number 2B, after I explain why, and knife number 3 as a plaster. Then hook 45 degree. This is the name that we are labeled in our operating room for the knife. For the suction, there are four sides, and the sector 1, 2, 3, and 4. But the first sector have a diameter very small, 0.6. Is very good to work about stapes, facial nerve, and very delicate for delicate dissection. For the knives and sector 4 have a 0.9 millimeters of diameter. Is more large, very good to avoid obstruction during the dissection, and very useful in adductus ad antrum, and when the sinus tympani is very proof on hypotympanum. The other instrument very useful in surgery in our experience are microforceps, very delicate, that we use to delicate dissection over the under-malleus, as you can see later, and the other steps, surgical step. Very useful. Then the curved upwards and downwards forceps that we use only with 45-degree optic in epitympanum and in retrotympanum. Okay. Now I see some practical example showing instrument in different surgical steps. Starting with the local anesthesia, we are used to praise it as the most of auto surgeon, even when the general anesthesia is programmed, in order to have a better hemostasis. In our experience, we prefer to do this step using ear speculum with microscopic approach. Indeed, we can see in the video making pressure with on the external canal. We can obtain a better diffusion of anesthetic under the periosteum toward to annulus, and so we have a good hemostasis. it's very important to see the skin white. We have usually the anesthetic under the periosteum and have a good hemostasis. Okay. Other surgical step. In this video, I show the use of a 45-degree hook. Is very useful for the scarification of a margin of a tympanic membrane before laryngoplastic. Is very useful, this instrument, with suction aspiration and complete with a little forceps. Other steps, the tympanometer flap. In these cases, we use a knife 2 in the first time and 2B in the second. Why? Because in the first step is very useful to use the circular scalpel with posterior hole to avoid the damage to skin of a tympanometer flap. And successively, you use the knife 2B with the interposition of a cottonoid. And in these cases, in this mode, you have a good hemostasis, and you can see very well the annulus and the other structure. You can change the instrument without damage to the skin, as you can see from video. For the vertical incision, as you can see, knife number 3, and read the same steps. First, sometimes you use also molecular scalpel to have a good hemostasis, as you can see, but this instrument is very useful, and then Professor Bonali speak about this instrument. First step without cottonoid, with the whole posterior of the circular scalpel, after cottonoid and the anterior hole of the instrument. It's very useful in this mode, in my opinion, use this instrument. About the section, the handle of malleus and umbus, I use usually an instrument very useful. The sickle knife is knife number 1, and this step is very easy with this instrument. So you can cut the periosteum over the handle of malleus. In the other, you see better this in endoscopic surgery. We prefer ways to remove the skin from malleus because it's more easily after to see the tensor fold area in this mode. It's very important to remove the skin over and open the operatory field. In the other video, you can see the same step in right ear, and we can complete the dissection also with the little forceps, like I said before. The first step, okay, this is the little forceps, is very useful for dissection. In the last time, we can cut the fibrous tissue on the end of dissection with a little scissors. Okay, other surgical step, very important, is the dissection of folds and the cholestatoma matrix and the opening of ventilation routes. You can see with the one dissector 1 is very thin. restoring the ventilation route, and then the remotion of the skin over the ossicular chain with first with a single knife, and then you can remove the little residual with the molecular scalpel, as you can see later. Okay, the other video show the same step, and with opening the tensor fold, okay, to restore the ventilation over the epitympanum. Okay, about the atticotomy in transcanal endoscopic ear surgery, you can perform this step with various instruments. I remember that we have one hand only. So the piezo surgery is very useful. As you can see, it's possible to remove the bone in a clear operatory field under water, and is very useful. Naturally, it's possible to realize this step also with curette is the other possibility is with the drill with protect bore. As you can see in these cases, in the microscopic approach, it's possible to see the drill with the protect bore, which is the tube. This tube helps the protect or the optic from injuries, as you can see in the video, because you put the tip of optic near the bore, so it's dangerous. In this mode is easy. Okay, about the dissection of cholesteatoma matrix is an important surgical step. You can use the second sides of the sector. Is in my opinion the more useful instrument because it's very strong. It's possible to remove also a little piece of a bone in some cases. It's very useful in the sinus tympani, in the epitympanum, as you can see, and in instrument very useful. Then I show the use of the third and fourth sides when I work in proximity of adductus ad antrum and in the antrum, as you can see from video. Is very useful when the sinus tympani is very deep, very proof. The instrument is very useful in this step, as you can see in some video later. Yeah, the size one is very thin, is very useful when used when works near the stapes, as you can see in this video. This particular video, there is a facial descent, a procedent, and the matrix under the stapes is possible to remove with very delicate maneuvers. Used also the laser forceps. Underwater is possible to see some residual of matrix that, as you can see later, is possible to see after the low pressure irrigation. About this specific methodic, I like very well the hydro-assisted endoscopic session because, in my opinion, the irrigation permits three very important goals. First, the irrigation of a target specific areas that is impossible to obtain with the external irrigation. But in hidden areas, it's important to have an instrument, the angulated instrument that can irrigate in specific area. The other advantage is best highlighting of a cholesteatoma matrix compared to other tissue, as you can see first. Now you can see I explain in the next video, because the skin swell under water. The mucosa, no, is the same with irrigation. And the third goal, and that the water produce a magnifying glass effect. Okay, you can see a short video that show this concept. As you can see, the skin is swell. It is at the end of surgery, and we can see the residual skin that is I highlighted in this mode. Okay, so we repeat the advantage: cleaning in target areas without removing the instrument from the surgical field, best highlighting over the cholesteatoma matrix compared to the other tissue, magnifying glass effect. Okay. We still working in progress the new connector with possibility to shift the irrigation and aspiration, but is working in progress. Okay, now we start with some clinical cases to show the various steps together. Okay, this is a tympanomedullary flap in a myringoplasty and ossiculoplastic technique. You can see the same procedures to remove the skin from the malleolus and put inside the graft. In these cases, we used an heterologous graft, and very useful in a transcanal approach to avoid skin incision, and put under the cartilage and a little fragment of hydroxyapatite to realize an ossiculoplasty to have a good functional result. Replace the tympanomedullary flap and check, is a very important point, the anterior angle and the position of the skin over the graft. This is the result at 50 days post surgery. Okay, this is a video very quickly for the time. Is a mesotympanic pocket retraction. You can see the skin incision vertical with plaster, and the tympanomedullary flap procedures. You can first with the circular scalpel knife 2A with the posterior hole, as you can see before. Then you put inside a little cottonoid and change the instrument with the knife 2B with the anterior hole. The cottonoid has an role, important role to avoid damage to the skin. With the plaster, remove the tympanomedullary flap
in the direction of
in direction of hypotympanum, and begin the remotion of the pocket retraction with the suction dissector number 1 is very and now there is the skin near the incus and the stapes is a very delicate maneuver, and use in these cases the single knife number 1, and it's very easy in this mode, and complete with the dissector 1. There is a little residual skin that after I remove with 45-degree optic. Okay, corda tympani. In these cases, there is a jugular bulb, very high, and the anatomy is not possible to see. Very useful, this downwards forceps to remove the residual skin, and 45-degree optics permits to see very well this area, sinus tympani, jugular bulb, round window, is non-evident subiculum. Subiculum is evident, but funiculus is not possible to see because there is not, in these cases, there is not, it's possible to see a little ponticulus, is a good anatomy, and very useful, the little forceps, as you can see. But after we remove the skin over the handle of malleolus, to see better the tensor fold area, to restore the ventilation of epitympanic spaces with the overture of a tensor fold. The little forceps is used in these cases, plaster, knife number 3. The isthmus is okay. Instead, there is a closer of the tensor fold area. Usually, this step is possible to realize only if you remove the skin in this area, okay, and perform the overture or with a longer peaks, 45, 90 degree peaks hook, or as I prefer, with the first sides of the sector, as you can see. Okay, this is the overture of a tensor fold, and we are in this mode. I restored the ventilation route. Okay, this is the reconstruction. We prefer always to use the cartilage and the perichondrium of tragus in 2 steps. First, you put inside the cartilage in this mode with because it's possible to put in various sides the cartilage, and in second step put inside the perichondrium. This is the final step. Replace the skin, and is a very easy technique. Okay, put inside after a check of anterior angle and the position of the skin, and we put inside the gel foam spongostan, and that we can remove after 50 days. Second cases is a epitympanic pocket retraction. In these cases, I show the atticotomy with the curette. Is very useful, is an economic system to perform this step. Okay. The little forceps is used to dissection. Non per strappare, come si dice?
Scratch.
It's very important to use the forceps to dissection, not to stretch the skin. Okay, the movement is very important to avoid the damage of a tip. The second sides of the suction dissector is used to remove the skin of under the chain. We had removed the id of malleolus and the incus to see better the epitympanic spaces, medial portion of the attic. With the 45-degree optics, you can see the remotion and you can see better this area with 45-degree. Cottonoid is used to hemostasis and to avoid damage to facial nerve that stay under. Okay, remove the skin. The other cases is a pocket retraction 4 type. Is very extensive in the sinus tympani, tympanometal flap with the same procedures. In these cases, we remove chorda tympani because interesting from cholesteatoma matrix. Okay, it's better to cut to avoid neuromas, secondary neuromas. We remove the incus that is with erosion, and with 45-degree and downwards forceps, remove the skin over the stapes with delicate maneuvers, and shift after the dissection with first sides. And I use always the same instrument: knife, single knife, little forceps, and the first sides. We continue the dissection in sinus tympani and in the round window. Under the bridge, there is a little fragment, and you can remove with a dissector and continue the dissection in hypotympany with the other one. With the low pressure irrigation, you can see a little fragment of skin that it's possible to remove with the molecular scalpel. This is very useful in these cases. The reconstruction is in the same mode with 2 steps. First, the cartilage. In these cases, we use a double layer of cartilage to obtain a good columella effect for a good functional result. In fact, you use a double layer to have just sides. Over, we put the perichondrium and check the position of perichondrium with 0-degree optics very well, and at the last end put inside the spongus. And this is the result after 2 years. Is a good functional and anatomic result. The 5 clinical case is an attic cholesteatoma lateral to ossicular chain. Is very useful, the instrument for remove the fold in the isthmus area. In these cases, we restore the ventilation route. We prefer in these cases perform the dissection of the incudo-stapedial joint to avoid cochlear injuries, and remove so easy the matrix of cholesteatoma around the chain without pericoli?
Dangerous.
Danger, without danger. Okay. The little forceps and the aspirator is very useful in for this section, and also at last is possible to perform the remotion of a little fragment over the circular chain, also with the help of a resonance scalpel, as you can see from last second. Okay, the little forceps. Okay, now we open the TensorFloat with the same instrument used before. Okay, open Overture and the molecular scalpel to remove the little fragment. First, use the molecular scalpel, and after is more easy to remove with the pick the residual. In these cases, we are performed also a second look after 1 year without residual cholesteatoma. We are checking. Okay, control the isthmus areas and the reconstruction with the same method in 2 steps. First, we used the cartilage to reconstruct the tympanum and the attics, and in second step we use the perichondrium over. Okay, it's possible to cut a little fragment inside. Okay, the perichondrium with Adelaide technique, replace the tympanomedullary flap, and put in the result is 1 year and after surgery, a good functional result. We perform always second look, as you said before. Okay, the last case is a very short video, but about this pathology Ali speak about. So the same step for the tympanomedullary flap, and you can perform the step surgery with the microscope or endoscope. It's the same result. It's very useful, the endoscope technique, in our opinion, especially when there is some malformation or difficult I thank you for the attention, and passo la parola. I give the word to Professor Nani. Thank you. Yes.
All right, Professor Panditi, thank you very much for this great presentation. Even though you already talked about a lot and gave us a very deep insight into your technique, into your approach, we already received quite a few questions, but again, those will be addressed in the very end. At this point, I would love to hand over to Dr. Bonali, who will cover Professor Prezutti's presentation. So good morning to Italy, to Dr. Bonali. Good morning. I hope you can hear me.
Thank you very much. Good morning.
Excellent.
Yeah,
Perfect.
I can hear you very well.
So we're all excited about your next.
So thank you.
Yeah, we're all excited to hear what to see what you have to say. So the next 2 terms are all yours. So I will sit back and listen to your presentation. So good luck from here.
Okay.
All right.
Thank you very much.
Okay.
And thank you very much also for your kind invitation. I am very proud to be here. And I will start with my first presentation. Just 1 second. Okay. So I will start with the first presentation about otoneurosurgery. Unfortunately, Professor Presutti is not here because he's in the OR, but he sends you his greetings. So let's start with the first topic that is about acoustic neuroma surgery. So as we all know, the management of acoustic neuroma, when you have large masses or relatively small masses but with hydrocephalus or highly symptomatic tumors or masses with cystic areas, we all know that the main and the best indication is surgery. So of course we have different cases in our practice, because we can have relatively high neuromas with a compression on the brainstem, or small neuromas inside the internal auditory canal. So we can have different cases, and we have to manage different cases in different ways, of course. So this is just an article to say that this is an article published in 2016 that is a literature review that shows in 37 articles with more than 4,000 patients included that age and sex does not seem to correlate with tumor growth, and neither hearing loss nor vertigo as the presenting symptom can predict tumor growth. So we cannot conclude that a large tumor at presentations is more likely to grow during follow-up, and the location also of the acoustic neuroma cannot predict the tumor growth. So we cannot say which is the growth of every acoustic neuroma in our practice, and we have, of course, to follow up the patients, but we have also some weapons to treat this pathology after, of course, a wait and scan if the acoustic neuroma is small. But there are three main factors that seem to correlate with the rapid growth rate. And when we manage an acoustic neuroma and we have cystic components in particular, the management is different, because we may have an hemorrhage inside the cystic component, and so we are more, for us is better to operate even if the acoustic neuroma is not so big. In our clinic, for the management of the acoustic neuroma, we keep in mind the general conditions of the patient. If the patients have only one hearing ear, and if the patient is old, of course. If there are impending neurological condition, the rate of growth of the tumor, and so we have different ways of treatment in case of poor conditions of the patient. If we have one hearing ear, or if we are in front of the patient that is old. So the main techniques in literature to treat an acoustic neuroma are the transmastoid approach with the translab, the retrosigmoid approach, and I will show you also our technique that is the transcanal approach with the endoscope. Traditional approaches, of course, are the retrosig, the translab, and also the middle cranial fossa approach. And here you can see in a CT scan, which is the area of drilling in the translab approach to reach the acoustic neuroma, and the area of drilling of the retrosigmoid approach with the craniotomy. And in our experience, when we have big acoustic neuromas, we use a combined retrosigmoid and endoscopic approach, because when we use the endoscope in combination with the retrosig approach, we can be faster, we can have better surgical dural repair, we complete visualize our CT angle, and also we can better visualize the fundus of the internal auditory canal. And in our experience, we can also perform a more accurate dissection of the facial nerve. And in many cases, we can also preserve the hearing. In some cases, not many, but in some cases, we can preserve the hearing. So this is the position of the patient during the combined retrosigmoid and endoscopic approach with the Mayfield holder to maintain in place the head of the patient. And this is the area of the endoscopic approach. So after performing the craniectomy or the craniotomy, we can put inside our endoscope in this way and reach the internal auditory canal that is here, especially with angle lenses like 45 degrees angle lenses or 70 degrees also. And as you can see here, during the endoscopic resection inside the fundus of the internal auditory canal, we can perform radical excision, but also we can visualize very well the facial nerve and the cochlear nerve. So we can also try to spare the function of the hearing function during our dissection. And in particular, we can also try to preserve the anatomical integrity of the facial nerve. So the key points are this. So CP angle evaluation with identification of the main neurovascular relationships with the endoscope. So also before removing the tumor, the dissection of the schwannoma from the facial nerve at the level of the anterior lip of the porus, that is the portion where there is the higher vulnerability of the nerve. The dissection of the intrameatal portion of the vestibular schwannoma, because of course, when we perform the extrameatal excision, we use the microscope. But if we want to limit the drilling of the posterior wall of the internal auditory canal, we can use the endoscope. And we can also check the radicality of resection, of course, at the level of the fundus of the internal auditory canal. And in some cases, it's also possible to repair the perimeatal cells dehiscencies when we face with this problem. And at the end, we can also check the CP angle structures also after vestibular schwannoma removal. This is an example of what I'm saying, because we are at the beginning of the procedure. We have our acoustic neuroma here, and we can check here. We can see the sixth cranial nerve here and the relationship with vessels and with the brainstem. So it's very important because you can perform with the microscope the extrameatal dissection, but you are aware of where are the main neurovascular structures. And we can also find the mixed nerves, the fifth nerve here. And so it's easier for us, even with the microscope, after this evaluation, to remove the acoustic neuroma in a safe way. After here, this is another slide that shows you what I was saying before, because at the level of the anterior lip of the acoustic porus, the facial nerve is more vulnerable. So when we can use angle instruments like Thomas dissectors, or especially Zini dissector or other curved instruments, to remove the acoustic neuroma, but we can magnify and see very well the anterior lip of the porus and the facial nerve in order to preserve it in the more in the higher in the vulnerable point, like here. So as you can see, and this is a drawing by Professor Marchioni from Verona. That shows you the anatomy of the CP angle during an endoscopic approach. And as you can see here you have the acoustic facial bundle where you have your acoustic neuroma. Here is the cerebellum, and here you have your 9, 10, and 11 cranial nerve, and here you have the fifth nerve. So here you have the entire anatomy of your endoscopic approach. So this is an example of an acoustic neuroma removal through the intrameatal portion of an acoustic neuroma with the 0-degree endoscope. As you can see here, the sixth cranial nerve, the fifth cranial nerve, and the acoustic facial bundle. And here you have the tumor. And here is the removal with the 45-degree endoscope. This is the internal auditory canal, and this is the facial nerve here. If you use the 70-degree endoscope, it's very useful because you can see very well the fundus of the internal auditory canal, also at the end of the dissection. Here you can see the falciform crest at the end of the dissection, and so you can see not only the nerves, but also the entire fundus of the internal auditory canal. So you can be more radical, and you can be sure that you have removed all the acoustic neuroma. So the drilling of the posterior wall of the internal auditory canal can be reduced due to the endoscope. So there is less risk of perimeatal cell opening. There is no risk of opening of the ampule of the superior semicircular canal, and there is, of course, also less intradural bone dust. So this is very important. As you can see here, you are very close to the internal auditory canal with the singularis foramen. And here, if you drill a lot, you may open this. So if you go with the endoscope and you can check with the endoscope, you avoid drilling of this area. And this is very important. And as you can see here, this is the comparison between repair of perimeatal cell opening with the microscope and with the endoscope. Of course, this is possible also with the microscope, but have a look at the quality of the images and of the on the magnification of the structures during a microscopic approach and during the endoscopic approach. It's easier to check and to perform your closure with the endoscope, in our opinion. And at the end of the removal, you can see again the neurovascular structures after the tumor removal. Here again, you can see here the 6th cranial nerve, the 5th cranial nerve here, the acoustic facial bundle here, and so you can check the radicality of your excision. This is another case of retrosig removal for a COS2 free acoustic neuroma. And as you can see here, you have a very highly pneumatized bone. And you have to keep in mind this also regarding the perimeatal cells. And as I said you before, as you can see here, after the craniotomy and the dural incision, you open the cerebellopontine system. And so you have a CSF leak. And after that, there is a decompression of the area of working, and you can dissect with the microscope the mixed nerves. You identify the tumor here, and so you can check with the microscope at the beginning, and you can, of course, create your field of working, and you can identify the facial nerve in the CP angle with the stimulator. And I can skip some of this video. Okay, you coagulate the vessels in order to avoid bleedings during your procedure. And after that, you start with the dissection of the nerve. You identify the intrameatal portion of the acoustic neuroma, and you can start to remove with the micro. Okay, you identify the dura of the internal auditory canal here. And after that, you start to the cavitation of the tumor. And after that, you start, after removing the extrameatal portion of the acoustic neuroma, you can start without any massive drilling of the posterior wall of the internal auditory canal. You can start with your dissection with curved instruments. You can detach the acoustic neuroma from the acoustic facial bundle, trying to preserve, of course, the functionality of the facial nerve and the cochlear nerve. And after that, if you have also adhesance of the bone, you can also fix this adhesance. But you can, before you check if there is a residual of acoustic neuroma inside the fundus of the internal auditory canal with a 70-degree angle endoscope, and you can remove it with curved instruments. So you can reach a very you can be aware of your radicality, and you can also fix some decencies of the bone. So starting from this, we have tried to understand the anatomy to perform another approach with the endoscope and to perform an exclusive endoscopic approach to the internal auditory canal. We started from the surgical anatomy, from external to the internal auditory canal, and after several dissections, we performed the first operation in 2013 of a cochlear schwannoma removed through an external auditory through the external auditory canal by a transcanal exclusive endoscopic technique. So we go on, we use this kind of corridor from the external auditory meatus, and we open the promontorium and we go inside the internal auditory canal. Of course, in these cases, you have to have an hearing loss before the operation, because you have to open the cochlea and you have to close the middle ear. So it's important that the patient is already deaf. And this is the CT scan coronal plane that shows you the area of drilling. So you go inside the external auditory canal. You remove the tympanic membrane, you drill the area of the promontory region, and then you go inside the internal auditory canal. So this is your area of working here. And this is the anatomy, another drawing by Professor Marchioni that shows you the anatomy of the facial nerve from this point of view. So as you can see here, you have the second tract of the facial nerve, the geniculate ganglion here with the great petrous nerve, and the first tract of the facial nerve. And as you can see here, there is a very narrow angle in this position between the first tract of the facial nerve and the second tract of the facial nerve. This is the lateral semicircular canal, of course, the dura, the middle cranial fossa dura here, the carotid artery anteriorly, and the cochlea here. And as you can see again, this is the spherical recess, that is the area where the inferior vestibular nerves end. And this is a very important landmark because as you can see behind the spherical recess, you have your facial nerve root. So it's very important to know where is the spherical recess, where is your vestibule, and the cochlea open, the basal, middle, and apical turn of the cochlea. So this is again a dissection that shows you the anatomy of this approach. The facial nerve second tract here, geniculate ganglion here, great petrous nerve here, and the spherical recess here. So I think that the root of my facial nerve, even if I haven't already opened the promontorium, is this, because it goes from here in this way at the level of the spherical recess here with the narrow angle. Going on with the dissection, we open also not only the vestibule, removing the stapes, but also the basal turn of the cochlea here and the middle and apical turns of the cochlea here. So as you can see here, there is the lamina spiralis and the middle and apical turns of the cochlea. This is the opening of the, another important thing is that where is the projection of the internal auditory canal? You have to stay in the bone in between the cochlea and the vestibule. So in the vestibulocochlear bone here, and if you open here with your drilling, you reach this condition with this visualization. So the facial nerve here, the second tract is here in this way, the inferior vestibular nerve here, and the cochlear nerve here. So if you go on with your dissection, you can see the facial nerve is in its entire course here. One, the first tract here, the geniculate ganglion here again, and the second tract here. So this is the anatomy. If you go inside and you try to check the fundus of the internal auditory canal, the cochlear nerve here, facial nerve again, and the inferior vestibular nerve. So this is another dissection, but just to show you again the projection of the internal auditory canal. Here you have your vestibule after removal of the stapes. Here you have your cochlea, the facial nerve second tract here, the cochleariform process that is overturned, and here you have the projection of the internal auditory canal. And if you open, you can find the facial nerve, and you can see the entire dissection of the facial nerve in this dissection with all the second tract, the geniculate ganglion again, and the facial nerve. So which are the main indications of this technique? A tympanic cavity cholesteatoma with medial extension towards the inner ear structures, so cochlea, vestibule, and internal auditory canal, a small symptomatic or growing acoustic neuroma with exclusive extension to the internal auditory canal fundus, and a cochlear schwannoma with or without internal auditory canal involvement. Which are the prerequisites of this surgery? Of course, you cannot perform this surgery without performing several dissections, but also several procedures on middle ear, because this is very important. You have to know the middle ear anatomy and surgery, and after that you can go beyond and to go inside the internal auditory canal. So this is very, very, very important, because it's not easy at the beginning to perform one of these approaches. So this is the first case, but this was a cochlear schwannoma, and in this case we fixed at the end the tympanic membrane, but this is not important because you can also close to perform a cul-de-sac closure of the external auditory canal, because you don't need to reconstruct the tympanic membrane. So this is the canalplasty. Here we enlarge our drilling. Here you can see the ossicular chain, the malleus, the incus. You have to detach the incus from the stapes here in this way, remove the incus, remove the malleus, of course, because the ossicular chain is in between your area of working. Here you have your facial nerve and the cochlear and the cochleariform process. The stapes is here. This is the cog. And this is the stapes. You have to remove the stapes in order to have a look at the spherical recess that is here. And this is an important landmark, as I said you before, for the facial nerve. You can also use a piezoelectric device to remove the bone and reach, after cochlear opening and vestibule opening, the internal auditory canal. And here you can see the acoustic neuroma. After that, you have, of course, some CSF leak. And I will show you the importance of magnetic instruments, in our opinion, to suck the leak and at the same time remove the acoustic neuroma. Here you can see your vestibule here and your acoustic neuroma. We can go on with the dissection. We go inside the internal auditory canal. We extend our drilling with the carotid artery anteriorly, the middle cranial fossa superiorly again, facial nerve posteriorly, and jugular bulb inferiorly. And we are able to remove our acoustic neuroma and to reach the radicality of excision and the visualization of the internal auditory canal. So we check at the end, we can see the nerves, and we can go inside to check the fundus of the internal auditory canal. This was the first case, and of course, after that we made several other surgeries for this approach. This is another case, but it's similar. So it's I can show you the CT scan. We have an acoustic neuroma that is not so big and does not impress the CP angle. And here we can remove this intracanal acoustic neuroma with the same technique. So the steps are the same. I show you only the last part of the video, and you can see again the removal of the acoustic neuroma after drilling and the visualization of the pathology, the CSF leak, of course. And at the end, you can check, after, of course, through the dura, the fundus of the internal auditory canal in order to check your removal. And this is the closure. We close with fat the defect of the promontory region, and then we perform a cul-de-sac close. We close also the eustachian tube orifice, and then we cul-de-sac closure the external ear. So this is the result at the end of the procedure and the area of working. And after that, and this is the result on the facial nerve. After that, we extended our approach, and this is the last part of my presentation, with an endomicroscopic combined approach to the internal auditory canal in order to remove via the transcanal approach also bigger acoustic neuromas with an extension also at the level of the CP angle. This is in this case, you have to know your landmarks, because if you work between carotid artery, facial nerve, middle cranial fossa dura, and jugular bulb, you have a very big area of working, and you can also use the microscope because you are in a straight way, in a straight route, and so you can put your microscope and work with the microscope, and after that switch to the endoscope. So as you can see here, we have this acoustic neuroma here with this extension, and this is the audiogram, and this is the dissection. So as you can see here, it's different because we perform a retroauricular incision. We go inside the external auditory canal. We perform a canalplasty. Here you can see after removal of the circular chain with the microscope, the Jacobson nerve here, the round window area here, the promontory region here, and the chorda tympani here, and the stapes here, of course. If we go on with our dissection through the microscope, we can see again the anatomy. Let me skip a little bit. Sorry, but okay. You can go on with your canalplasty here in this case. And after that, you can see again the anatomy. Region here, jugular bulb here, round window here, stapes here, and second tract of facial nerve here. So this part is made only by the microscope. We can also check and expose the carotid artery anteriorly in order to have our area of drilling. You have to stay here because anteriorly you have the carotid artery, of course, inferiorly the jugular bulb. After this part, we can open the cochlea. Here you can see the basal turn of the cochlea with the tympanic scale and vestibular scale and the basilar membrane. The round window is here. The oval window is here. So this is the opening of the cochlea. After that, you have you go on with your dissection, always with the microscope, and you reach again promontory region and the dura of the internal auditory canal here with your tumor here. The landmarks are the same. So the spherical recess, you have to know where is the facial nerve, and you have to open in between the cochlea and the vestibule to reach the internal auditory canal. You can open the dura, of course, of the internal auditory canal, and then you switch to the endoscope, and you check after dura opening the CP angle and the internal auditory canal in this way, and you can perform the removal of the acoustic neuroma in a safer way. So you have your tumor here, you go on again with the microscope with the dissection of the tumor, but before you check with the endoscope your anatomy in order to be safe, like in the retrosig approach. And we can skip again and go at the end of the removal. When you perform this removal, then you can check with the endoscope inside, and you can check the neurovascular structures. The fifth nerve is here, the brainstem is here, and then you can control bleedings or the radicality of excision. Here you can see your seventh nerve, and the fifth nerve. This is the incision, the retroauricular incision, and this is the patient at the end of the procedure, walking in our department, and the facial nerve function at the end of the procedure. But in some cases, I have to say, in the majority of the cases, when we have to perform now the dissection of the acoustic neuroma with the CSF leak, we also use these instruments that are very useful for us. These are the Panetti instruments, but longer, and they are very useful because you can avoid to have CSF leakage in front of you during the dissection that can be very, that can create some troubles during the dissection of the neuroma. And so you can suck and dissect at the same time your acoustic neuroma, your vestibular schwannoma. And this is safer also because you can see better without the CSF leak, and you can preserve the nerves and the vessels, because of course we have to avoid bleedings inside the CP angle during this approach. Of course, we can fix a bleeding because we can open from behind in a retrosig approach and control the bleeding if we have a major bleeding. But in order to avoid this, we can use these instruments. And as you can see, this instrument, the tip of these instruments is very useful because it allows you to dissect the tumor while sucking the CSF leak. So I can show you the last video, a recurrence of vestibular schwannoma. This is again the anatomy, jugular bulb, basal turn of the cochlea here, oval window here, facial nerve here, and carotid artery here. And here we open to reach the internal auditory canal. And when we perform the dissection, as you can see, we go inside, we have CSF leakage. And if we want to control this leakage better and in a safer way, we use these instruments because we think that are very useful. As you can see here, they are very long instruments, and you can dissect the tumor with less liquid inside your field of working. And as you can see here, and then you progressively detach the tumor from the nerves, the vestibular nerve, while preserving, of course, the facial and if possible, to preserve the cochlear nerve, because in this case you open the cochlea and you have a complete hearing loss. But usually these patients are already deaf. So this was my last slide. So I thank you very much for attention. And if you have questions, I will answer at the end of this webinar. Thank you very much.
Thank you, Dr. Bonali. That was very, very interesting as well. That was very nice.
Did you hear well?
Can you hear me?
Did you hear well my presentation?
It was excellent. The sound,
Perfect.
the acoustic was perfect. So even the video quality was excellent. Thank you very much. So at this point, I would love to actually hand over to my colleagues that were following up on all the questions that we gathered over the past 90 minutes. So I would love to hand over to Carolina. Are you out there? Can you hear me? Carolina?
Yes, I am here.
All right, perfect. So I would love to pass it over to you now so that you can handle and address the all questions that came up accordingly. Is that okay for you?
After the other presentation or now?
Dr. Bonali, there's one pending.
Yeah.
Yeah?
Yeah, there is one pending. Yeah.
Okay, so because I
May I go with
you
the
just continue.
the
That was announced in the beginning, so you continue with your
okay.
and
Okay, go on. Thank you.
okay, perfect.
So, just a second to share the screen again. Okay. Okay, so next presentation is about some videos of real cases and our main indications in endoscopic ear surgery. So let's take a step back and talk about all the indications to endoscopic ear surgery in our experience. So what does it take to get started with the endoscope? This is very important because you have to have endoscopic skills, and it's better if you already have some skills in the endonasal surgery because of course it's different, but if you know how to manage the structures with one hand is better. Of course, very, very mandatory is the anatomical knowledge after several endoscopic dissections. When we started to perform the transcanal endoscopic approach to the acoustic neuroma, the first time we felt very lost. We didn't know how to do it. And after several dissections, we understood the anatomy and how to reach the internal auditory canal. The equipment is very important because you have to have, of course, an endoscope with a better 3 millimeters diameter, because sometimes with the 4 millimeter is very difficult to work inside the external auditory canal with the instruments. And the 0 degree and 45 degrees endoscope are very important to check also the hidden recesses of the tympanic cavity. The length in our clinic is 15 centimeters. And of course, an HD camera and the monitor to work. Professor Panetti has already talked about other important instruments. Here we write optional, but in our daily practice, we use always banded instruments, piezoelectric devices, molecular resonance scalpel, and Panetti instruments. And of course, you have to also to manage the bleeding. So you have to know how to you have to talk with your anesthesiologist to maintain the blood pressure low. You have to inject at the beginning of the procedure your external auditory canal to avoid bleeding, and we also use cottonoids with adrenaline. And of course, it's very important to know the microscopic techniques, because we always have the microscope in our OR, because if we have to switch or to start with the microscope, we have to know how to do it, and the preoperative radiological study. This is the standard otological instrument set, but Professor Panetti has already shown you this set, and these are the different angles of the lenses, and you can see that you may see different areas of your surgical field with the angled lenses. Like in this case, you can see the stapes here with the 30 degrees or the 0 degree. With the 45 degrees, you can go also inside the sinus tympani, and with the 70 degrees, you can also check the facial sinus. So you can have different angles and different visualizations. So what do we need to start? Surgical skills at the beginning. So if you don't practice a lot for your surgery, you cannot perform this kind of surgery, because the learning curve at the beginning is very is very difficult and sometimes frustrating, but you have to go on. You have to dissect a lot, and then you have to start with the easiest cases, because we created a training program, especially for endoscopic ear surgery, and we think that you have to start when you perform your training in endoscopic ear surgery from here, from the external canal to the internal canal. So starting from easier procedures and then going inside, because if you reach here, there are many structures at risk, and so you may have more complications. So you have to start from the first step here and then go on with your training. So the first level, of course, is office-based for diagnosis and myringotomies. Level 2, you may perform tympanoplasties type 1 or explorative tympanotomies, and then go on, stapedoplasties, facial nerve decompressions, endoscopic resection of middle ear tumors, and at the end, you can go inside the internal auditory canal. So this is very important to know. This is the setting of the surgical theater. Of course, you have the surgeon here. The patient lays supine with the head rotated on the contralateral side. And here you have your monitor, and as you can see, also the microscope. And you have your anesthesiologist here. The position of the patient is this when you perform middle ear surgery, because you have to have a wide angle between the neck and the shoulder, because if you don't have this angle, you may have some difficulties in moving your instruments inside the external auditory canal. So this is very important. And as you can see here, the surgeon stays in front of the monitor, and we usually work standing up. But you can also work by sitting down. It's not important. It depends on your on the feasibility of your back and of your neck and of your shoulder. We usually stand up. And this is the main indications to exclusive transcanal endoscopic ear surgery. So myringotomy and tympanic tube insertion, grommet insertion, type 1 tympanoplasty, stapes surgery, eticholecystoma, mesoepitympanic cholesteatoma, and retrotympanic cholesteatoma. And also epitympanic cholesteatoma with antrum extension and a sclerotic mastoid. This is called by the endoscopic open approach. So we perform an inside-out removal of the cholesteatoma from the external auditory canal, through the external auditory canal. These are the indications to exclusive endoscopic ear surgery, but we also perform many procedures where we perform a combined approach. So the endoscope for the tympanic cavity and the microscope for the mastoid. It's a closed canal wall up technique, but combined technique. The tympanic cavity portion of the cholesteatoma is removed through the external auditory canal with the endoscope. Of course, there are some contraindications like lateral semicircular canal fistula, the meningoencephalocele. If there is a massive mastoid involvement, in these cases, we perform a canal wall down technique, and the stenotic ear canal. This is a short video to show you a myringotomy, but I can skip because you all know how to perform a myringotomy. But I show you this because you can start with this with the endoscope, because you have to try with simple procedures to feel confident with your instruments with a one-hand technique. And then you can switch to, for instance, a transtympanic tube positioning. So in this case, you can see very well the anterior annulus of the tympanic membrane if you go inside, because you can magnify your tympanic membrane. And after that, you can put a T-tube for the ventilation of the middle ear. We also perform tympanoplasties type 1. So we perform a tympanomeatal flap. In this way, we usually perform a spot-by-spot incision with the hot instruments like molecular resonance or hot knife, and we detach the tympanomeatal flap from the bone. We scratch the bone. You have to feel the bone when you perform the dissection. After that, we identify the annulus and the chorda, and we go inside. We open the mucosa inside the tympanic cavity, and we reach the area. As you can see here, the chorda tympani and the annulus here, we reach the area of the perforation, And we usually use autologous material for tympanoplasty type 1. We use perichondrium or cartilage, or like in this case, a composite graft with the cartilage and one layer of perichondrium. We create an island of cartilage with one layer of perichondrium attached. And after elevating the tympanomeatal flap, we reach the malleus. We detach the malleus in case of anterior perforations from the umbus. And in our experience, we didn't experience any kind of gap in the hearing audiogram after this procedure, because in our opinion, the most important thing is not to detach the detachment of the malleus, but but you have to see very well, and in this case, the endoscope is very helpful, the anterior annulus. And when you put your graft, you have to know that this graft is positioned very well in the anterior portion of the tympanic membrane of the perforation, because otherwise you may experience a reperforation because your graft falls down, and so you may have a reperforation. In this case, you can check at the end of the procedure your graft positioning, and you can also put the other layer of perichondrium attached to the tragal cartilage with a second layer in this way to reinforce your tympanoplasty type 1. So this is another important concept. You have to, in our opinion, you have to preserve the mastoid when you have a cholesteatoma inside the tympanic cavity, because mastoid is very important for gas exchanges and buffer effect. So it cannot be the route to reach a cholesteatoma. You have to open the mastoid only when you need to do it, when you have to remove a cholesteatoma from there, not to reach the tympanic cavity. So it's very important for us, this concept, and also to restore the ventilation. When you so you have not only to remove the cholesteatoma, but also to prevent recurrences by opening tensor fold region and opening the isthmus, the main ventilation route to the tympanic compartment. But of course, we have some limits, because the antrum, in our experience, is the borderline between the microscopic approach, if you have a cholesteatoma inside the mastoid, and the endoscopic approach, if you have a cholesteatoma only inside the tympanic cavity. So the main indications to transcanal endoscopic removal of cholesteatoma are these. So mesotympanic, retrotympanic cholesteatoma, even epitympanic cholesteatoma without antrum extension, or with antrum extension but with a sclerotic mastoid. So we perform in this case the open endoscopic approach. So we drill in an inside-out way this area until reaching the end of our cholesteatoma extension. This is a case that shows you a cholesteatoma inside the tympanic cavity. And as you can see, there is an extension also medial to the ossicular chain. So in this case, probably we have to remove the ossicular chain. It's difficult to spare the ossicular chain, also because you cannot see very well the medial wall of the tympanic cavity, and also because you may have an erosion of your ossicular chain. So after the elevation of the tympanomeatal flap, you reach the tympanic cavity, and you can see the cholesteatoma matrix inside the tympanic cavity. So you can remove some of the cholesteatoma with the suction. After that, in this case, you have a cholesteatoma medial to the ossicular chain. So you remove the incus that is already eroded by cholesteatoma. And also we remove usually the head of the malleus. We remove the medial portion of the cholesteatoma from here. But as you can see, we can visualize very well the structures during the removal, like the round window here. And so we can be safe on structures like the stapes here with the stapedial tendon while removing our cholesteatoma. So we remove also, as I told you, the head of the malleus. And after this, you can see the facial nerve here, cochleariform process here, and the epitympanic space. So you can remove the cholesteatoma from the epitympanic space and be radical. And you can also check, of course, with the 45 degrees inside the antrum in order to check if your removal is complete. If we have some matrix that goes here in this direction inside the mastoid, we can switch. We have already done the tympanic cavity portion. We can go behind and perform a combined approach. In this case, it was not necessary because we removed all the cholesteatoma from the tympanic cavity. This is another case of a cholesteatoma. Here again, tympanomeatal flap, ossicular chain, and the cholesteatoma medial to the chain. we detach the membrane from the malleus in this way. We remove the cholesteatoma, but in this case, we were able to remove the entire cholesteatoma from the medial wall here without touching the ossicular chain. But we can see a portion of the cholesteatoma here inside the eustachian tube orifice. And this is, this is very important because the endoscopic approach allows you to, I have to come back, okay, to remove the cholesteatoma, but also to check for residual diseases, because if you leave a fragment of cholesteatoma in the eustachian tube orifice, you may have a big recurrence in the future. So you have to check that your subsides of the tympanic cavity are all safe. And with the angle lenses, is very easy to do it. You can check also the retrotympanic area here, and you can check if there are some cavities, some pneumatized areas that have fragments of cholesteatoma inside. You can open the area of the sinus tympani, and you can detach the mucosa to be as radical as possible. Another main indication for cholesteatoma surgery with the endoscope, for me, is the congenital cholesteatoma, because if you have a cholesteatoma like this, and you have to face up with the family, because these are children, so they have families behind, and they are very worried about the results, the functional results of their children. So if you can say that you have not to perform the retroauricular incision, that you can remove the cholesteatoma, and probably also while sparing the ossicular chain, this is very important for the families and also for the children, of course. So here you can see a sec cholesteatoma here, and this is the extension of the congenital cholesteatoma. You can perform, again, the same incision, same tympanomeatal flap, and go in the anterior portion of the tympanic cavity and see the metricus of the cholesteatoma. Here again, you have the incus, the stapedial tendon, the promontory region, and the malleus. After detaching the tympanic membrane in this way, and detaching the tympanic membrane from the malleus, you can see the facial nerve here and the cholesteatoma behind the malleus. With the delicate maneuvers, you can detach the cholesteatoma. Of course, this is a sec cholesteatoma. If you have an infiltrative matrix, it's not the same. But in this case, you can carefully detach the entire cholesteatoma from the medial wall and the anterior portion of the tympanic cavity, while leaving your your ossicular chain in place. So you can preserve your ossicular chain, preserve hearing, and removing completely the cholesteatoma. And after that, you can check again the tuba here, and you can reput the tympanic membrane without any kind of scar retroauricularly. This is a stapes surgery. I have to go quickly because we have not so much time, but this is a case of stapes surgery. We think that stapes surgery is in stapes surgery, you can, as Professor Panetti told you before, you can also use the microscope, because you can perform fast and safe procedure also with the microscope. But and as you can see here, this is very important. You can check your stapes and the relationship with the facial nerve, with the endoscope, with the magnification of the images. And so it's important not for the primary surgery, in my opinion. We perform endoscopic surgery for stapes in primary procedures because we are used to do it. But I think that the most important indication for stapes surgery is not here, but it's in particular cases, like revision cases, because if you have a case like this, where you have a prosthesis and fibrous tissue and adhesions on prosthesis and long process of the incus, you can magnify your view. You can remove all these scars without damaging the other structures like facial nerve. You can check the condition. You can remove the previous prosthesis. And after that, you can perform a safe revision surgery, and you are really aware of what's going wrong with the previous surgery. So this is very important. And it's important also in some difficult cases, like in this case, where you have a very, very decent facial nerve covering almost entirely the oval window. And this is the 45-degree view. And you can see here the oval window region. But with the endoscope, you can do it. Of course, this is not an easy surgery, but we can check, we can magnify our vision, we can see where the oval window is. We can also use some surgicel to push a little bit the facial nerve and to gain space for our procedure. And after that, as you can see, we go inside, we see the area of the oval window, we push a little bit the facial nerve in this way. And I think that with the microscope it's very difficult to do this because you can see very well. You can't see very well what's going on during your dissection. You can put some surgicel to push the facial nerve. And after that, you can drill your, you can drill, you can open your area, you can drill, you can perform the platinotomy, and after that you can put your prosthesis inside in this way. And as you can see, the function of facial nerve is, sorry for the audio, this is the condition of facial nerve after surgery. This was a surgery made almost 1 year ago, and the function of facial nerve is perfect now. And another important case is when you have, for instance, a persistent stapedial artery inside. If you have a big persistent stapedial artery, you have to work with the endoscope, because if you damage the stapedial artery, you may have a facial nerve palsy. So you have to see where is your stapedial artery here, and which is the course of this artery. But even in a case like this, with the endoscope, you can perform the platinotomy and you can put your prosthesis. But this is very difficult, and you have to see with this magnification to do this, because you have you cannot coagulate the artery, you cannot damage the artery. And so during this surgery, you have to be very careful. This is a very advanced surgery, of course, but you can do it. You can remove the suprastructure of the stapes. Sorry for the video because, okay, you can remove the suprastructure of the stapes, and after that you can drill very close to this artery, and at the end you can perform your stapedotomy, and at the end put your prosthesis in place. So this is the great value of the endoscope during endoscopic ear surgery. Of course, you may need also better instruments to perform this kind of surgery. And for instance, if you have a 4K monitor, there is a difference between SD camera, Full HD camera, and 4K monitor, because as you can see, the anatomical details are better with the 4K. But you can also work with the HD monitor, and it is very, very good. Professor Panetti already, I have finished. But Professor Panetti has already told you something about some instruments that you can use during surgery. And these instruments are important because in a case like this, as you can see, you have only one hand to fix your bleeding, and the bleeding is always present when you perform the tympanomeatal flap, even if you perform the injection or you use cottonoids with adrenaline. So you may need some instruments that help you to overcome this trouble, because usually inside the tympanic cavity you don't have this bleeding, because you have the bleeding during the tympanomeatal flap elevation, but inside the tympanic cavity, with the cholesteatoma, you don't have this bleeding. But in these cases, it's very important to have some instruments that can help you with the bleeding. So the molecular resonance, scalp cut knife, and so you can perform this spot by spot incision with the flap with this kind of instrument, and this is helpful to avoid bleeding and to elevate the flap safely. And you can also use the piezoelectric device to perform the atticotomy and to work underwater. Just one thing about the piezoelectric device: you have to work underwater, but you have to have a field very, very clean, because if you go underwater with the blood, it's impossible to work. You have to wash a lot and to clean the field before using these instruments. But these instruments is very useful because it spares the soft tissues while removing the bone. And in the end, last but not least, for us it's very important to use Panetti suction instruments, because Professor Panetti showed you some cases of surgery with his instruments. I will go a little bit inside the tympanic cavity and the internal auditory canal to show you two cases where it's very important to have this kind of instrument with banded and with some with a knife, with a curette, or other dissectors. Because if you have a case like this of paraganglioma inside the tympanic cavity, you may have a lot of blood inside. And if you have a glomus type A, you can remove it with the endoscope, but it's very difficult. And the Panetti instruments are very helpful in this case, because you can perform, of course, again, the tympanomeatal flap, but when you go inside, the paraganglioma starts bleeding, and it's very difficult to manage it because you have only one hand. So if you use this instrument, you can dissect the paraganglioma from the promontory region usually, and you can also coagulate the pedicle, of course. But if you don't have a suction integrated inside your dissectors, it's very difficult to remove it. And sometimes you may experience a switch with a microscopic technique. With these instruments, we haven't experienced any case of switching from endoscope to microscope, because we can dissect the tumor and at the same time suck the bleeding and clean the field. And the last case is this, a geniculate ganglion hemangioma, so another bleeding pathology. As you can see here, you have the antrum region here, we are inside the tympanic cavity, lateral semicircular canal, facial nerve second tract, and stapes here. And so we have to work in an area that is endoscopically reachable. Of course, you have to remove the ossicular chain, the head of the malleus and the incus, but you can reach the geniculate ganglion area. And here you can go go through this region towards the petrous apex in a suprageniculate way, and you can remove the geniculate, the hemangioma. But of course, in these cases, you have a lot of blood. And so with these dissectors, you can identify the facial nerve, suck the bleeding, and remove the hemangioma. In this case, the hemangioma was attached to the facial nerve, so we had to remove, to cut the facial nerve, and we performed the hypoglossal-facial anastomosis to restore the function of the nerve. But we identified all the structures, and we were able to remove the entire hemangioma with the aim of this instrument. So with this video, I finished my presentations. Thank you very much for your attention. And I'm ready for the questions if you have it. Thank you very much again.
Again, all right. Again, Dr. Bonali, thank you very much for your presentation, and of course for covering two parts in this webinar. We really appreciate that you jumped in for Professor Prezzutti. That was really excellent. Anyways, we are a little behind our time schedule, and I would love to go straight over to the question part now and hand it over to my colleague Carolina, who is located right now in Chile. So she will take over and manage all questions that popped up over the past 90 minutes. Carolina, are you ready to take over from here?
Yes, sure. It's a pleasure. Thank you very much, Matthias. Thank you, Dr. Marco Bonali and Dr. Panetti. It's a pleasure, as always, to hear you both in these very interesting lectures. And we have some different comments through our YouTube channel and through WhatsApp. And the first question I will ask to Dr. Panetti. I have here the first questions from Mrs. Vanaha Sipatasingam. What do you use for your atycotomy, Dr. Panetti?
Yes. I usually use the curette. Is a very fast system is economic and quickly. When I perform the step in endoscopic and or in microscopic technique. In the microscopic technique, sometimes with the transcanal approach, when the ear canal is large, I use the traditional drill with the 2 hands, aspiration and the traditional drill. Instead, in endoscopic ear surgery with transcanal approach, I prefer drill with the protect burr as like Skeeter or Visao or Benair. There is some device, but sometimes I use the piezo surgery, but for me is an optional, but is expensive and not always available. Professor Marco Bonali explained this concept better for me in his presentation. I thank you for the mention, Bonali, for my instrument. I am honored to collaborate with Modena School. Is the most important school in the world. Is the first that use the endoscopic ear surgery for the neuroma surgery. I just want speak about it. Very honored to work with them. Okay.
Thank you, Professor Panetti. You know that it's not only professional collaboration, but it's also friendship. So for me, it's a pleasure to work with you. Basically, regarding the dichotomy, it's the same for us because we usually use the curette. And sometimes, in some cases, you use a piezoelectric device. And in some cases, for instance, when we perform an inside-out technique for a cholesteatoma in the epitympanum with the antrum extension with a sclerotic mastoid, we use the burr because it's faster. But when we have to perform a small dichotomy, the curette is very good, and you can be very, very fast also with the curette. It's not a problem, and it's cheaper.
Yes, I agree.
Yes, always depend, of course, of the country, the options, the variety, but always is important to think in the low cost for each doctor. Very nice point. Other question, Dr. Panetti. Dear Dr. Panetti, after operation, how much days do you remove the spongostan tampons? Thank you.
Yes, thank you. I thank you for the question because before I perform a mistake, usually after 15, no 50 days, I'm sorry. 15 days, 20 days is, in my opinion, the just time to remove the spongostan. And sorry for my English again.
You have a lot of fun all over the world. I can say here from different countries, from Russia, for Indonesia, from you really have a lot of fans. Don't feel sorry for these little mistakes. Other question. For the question about the dichotomy, which instruments and which endoscopes are the most common indications for this transcanal endoscopic ear surgery?
What is your instrument? Okay, in my opinion, the best of to perform a lot of for endoscopy ear surgery to perform the great part of an instrument are knife 1, single knife, knife 2A, circular scalpel with the posterior hole, knife 3 plaster with suction channel on the right side. This is 3 important instruments, very, very important, that I usually use. About the sector, the most important is number 2, right and left side. Is a just compromise to sides, to suction is 0.9 millimeters, is strong to remove some piece of bone, and naturally the connector 70 degree because is useful. And in my opinion, this is the basic, is a minimal instrument to begin this surgery and to have the possibility to realize this surgery very easy. And also, but in second step, the sector 1 is very thin, is very useful near the stapes. This is my opinion.
Perfect. Yeah, Dr. Bonali?
I would like only to add one thing, because it's for me are the same instruments, but sometimes if we are talking about the articotomy and the check of the epitympanic compartments and the antrum, so I have to say that regarding the endoscopes, we usually use 0 degree and 45 degrees angle. In some selected cases, like when we have a very deep sinus tympani, or we have to check inside the antrum, but in selected cases we use also the 70 degrees angle, but because we have it for the acoustic neuroma surgery. But you can also work with the 0 and the 45 degrees. And sometimes to remove some pathology, some remnants of cholesteatoma from the antrum, I use Thomas Sands dissectors or Zini dissector that is very useful to scratch the bone in the antrum and to remove some remnants of cholesteatoma. So, and sometimes some bended angle tip Hartmann forceps to take the remnants of the cholesteatoma. So, but the instruments are the same as for Professor Panetti.
Yes, if I can,
Yes.
I just want to say another thing. The other very useful instrument with basic instrumentary for me is upward and downwards forceps, and the little forceps is very useful. I use always little forceps in Modena school. Say pinzina is the important. Yes,
Right.
about the sector 3 and 4 sites. The inspiration is by Fish excavator, Zini excavator, Thomasen excavator. The shape is similar. Okay. Thank you.
Perfect. Dr. Panetti, do you recommend to use in relation to endoscopes which length and which diameter? Because angulation is already covered, but the length and the diameter, in your experience, if you can, of course, share with us.
Yes, my preference is the same over the model and 3 millimeters of diameter, 50 meters of length. But to begin this surgery, if possible, to use the same optics that use for functional sinus surgery, because at the beginning I used the 4 millimeters, the same optic that I used for the functional sinus surgery. My preference naturally is for 3 millimeters, is a good compromise for a good vision, and diameter very small, so it's possible to operate also with a narrow ear canal, almost 4-5 millimeters, 3 for the optics and 1-2 millimeters for the instrument. Okay, with but if is a large ear canal, it's possible to use also 4 millimeters.
And thank you, Dr. Panetti. And in relation to the length, because in the market exists different kind of length, 11, 14, and in the nose, 17 or 18. You can use one is better than other. It's the same.
Yeah, about the length, I prefer 50 centimeter. 15, okay. My 50 is too long. Yes, 15 is for my experience is better, because when I use the instrument, I have the possibility to use the finger to stabilize the instrument. Okay. More longer is more difficult, but not impossible.
Perfect. Dr. Bonali, do you want to comment something in relation to the scopes?
Yeah, the length in our clinic is 15 centimeters, so it's the same. So, I think that around 15 centimeters is good. 14, it's okay. As Professor Panetti has just said, if you have 15 centimeters length, you can stabilize your optic without, if it's longer, you may have some bendings, but if it's 15 centimeters, it's very good. And regarding the diameter, of course, if you are at the beginning and you have a narrow canal, 4 millimeters diameter can be very, very, very difficult to manage with the instruments. But if you have to perform a simple case and you have a good and a wide external canal, you can also use 4 millimeters. I tried also, but one day I hadn't the 3 millimeters diameter. I tried with the 2.7, but this is not good because it bends a lot, and so you have some troubles in stabilizing your view. So 3 or 4 millimeters is perfect. Better 3.
Perfect. 3 millimeters, better than 4, of course. And sometimes when the doctors start this process to endoscopic ear surgery, maybe for just a myringotomy could be something, the optic they have, right? Because sometimes it's something you have there and it's okay.
Yeah, no, of course. But I also suggest you to try at the beginning. The level 1 of our training is also to use in the office-based practice. So you have to use the endoscope to remove, for instance, ear dewaxing. I know that is strange to say, but you have to start from there, because you have to. It's not so easy at the beginning. Also to trim the hair from the external auditory canal with the endoscope is a good exercise, because it's not so easy. So you have to start with that, also because with the endoscope you can check some retraction pockets to see if there is an epidermization. And so it's very useful. We always use before the surgery and after surgery the endoscope in the outpatient clinic to check the patient, because it's very, very useful, and you can train a little bit with your maneuvers and in the way you move your instruments and your endoscope.
Yes, that is a very good tip to all the doctors who are seeing this webinar. And the last question for Dr. Panetti we have here is, where did you harvest material tissues for the tympanoplasty?
Yes, thank you for the question. Okay, usually I use the perichondrium or perichondrium more cartilage, as you can see before, or tragus, because it's very easy to take this tissue, is near the operatory field, and is very useful, especially in pocket retraction and in large perforation. Sometime I use the fascia or temporalis fascia. Sometimes, but in these cases, I perform another skin incision. I don't like during endoscopic ear surgery to perform another skin incision. As you can see before, sometimes use the heterologous graft, in these cases porcine submucosa biodesign, especially when the perforation is posterior, is a good result. In a very large perforation, the result is so and so, because the time of the reassorbimento of the reabsorption is 30 days, 40 days. So in these cases, I prefer the cartilage. Is a very, very useful in my experience. About ossicle reconstruction of for the ossiculoplasty, when it's possible, I use cartilage when there is the stapes, the substructure of stapes. I put inside the cartilage one or double layer, or cartilage more prosthesis with Malefronte technique. Useful, simple, poco costosa, cheap, and sometimes titanium is very expensive. In my experience, I prefer use poor graft. Okay, what is the opinion of Marco? Are you
Yeah.
agree?
So we usually prefer autologous materials, especially for ossiculoplasties. And so for tympanoplasty type 1 or reconstruction of the tympanic membrane, we usually use tragal cartilage. And as I showed you before, usually we perform an island graft, composite graft with cartilage and a layer of perichondrium. And then we put another layer of perichondrium in the anterior portion of our reconstruction to reinforce the anterior part of the perforation and to avoid a reperforation in the follow-up. And sometimes we use also cartilage alone for the reconstruction, or a double block of cartilage if we have the superstructure of the stapes. And sometimes we also use the Malefronte technique with the prosthesis of the stapes prosthesis inserted inside, put inside the double block, and we put in contact the double block with the malleus and the piston of the stapes prosthesis with the stapes foot plate when we have to perform a TORP. And regarding other materials for ossiculoplasty, if we can, we use the incus with the autologous remodeled incus, or in some cases also the head of the malleus. We also use the head of the malleus in some cases, remodeled and put inside in between the handle of the malleus and the stapes. So we use autologous material if we can.
Perfect.
To avoid extrusions and other stuff like that.
Yes, yeah, it's good. Okay, now I will give the word to my colleague, John Ibanez, to make the questions for Dr. Bonali. Thank you, Dr. Panetti, and thank you, Dr. Bonali. Yeah.
If possible, I just want to thank my colleagues that work with me, Dr. Domenico Romano, Dr. Salvatore Sansone, and Dottoressa Nancy Maione, and special thank to Gabriella Panetti.
Yeah.
Thank you.
Thank you for all your collaboration and all your team, all your good disposition. Always is a pleasure to work with you. Now with Dr. Bonali, it's always a pleasure, and thank you very much. John, are you there? And maybe your colleagues can show their face.
Yes, thank you, Carolina. And also thank you very much to the participants for the questions that they have sent to on the live chat, but also to those who have sent their questions via email to export@spiegelandthijs.com. And actually, I wanted to read out loud some questions to you, Dr. Bonali. And one of them, one participant asked, and he was interested in knowing what was your experience in terms of learning curve? How long did it take you to adapt from using a microscope to start using primarily endoscope in your surgeries?
Okay. So first and the most important thing, I started my training in otologic surgery with the microscope because I still think that the microscope is mandatory for this kind of surgery. We are not surgeons of the endoscope or of the microscope, but we are a surgeon of the ear. So we have to know both of the techniques, and we have to know that if we have a big cholesteatoma, for instance, we have to use the microscope. Sometimes, usually when we have large cholesteatomas, we use only the microscope, for instance. But I started with my training was, I think, the best because I started with mastoidectomies during cochlear implants. So you have a healthy mastoid, you can perform your drilling, you can understand the anatomy of the mastoid during a cochlear implant, and so you can train. After that, I performed some procedures with the microscope and I switched to the endoscope. Of course, if you are you feel confident using two hands during a mastoidectomy, at the beginning it can be very, very frustrating. When you start with the endoscope, you have bleeding inside the external auditory canal, you don't know how to manage and you feel lost. But after that, after I think 10, 15 procedures, you can manage your external auditory canal very well in case of bleeding with cottonoids, with the injection before, you know how to overcome this problem. After that, when you reach the tympanic cavity, there is no bleeding usually, except for hemangioma or paraganglioma, but these are very, very advanced procedure with the endoscope. So if you have to perform a tympanoplasty, you will feel very comfortable with this technique because it's not difficult to work with one hand if you don't have bleeding. Let's think about it. If you work with two hands during microscopic surgery, what do you have in the other hand? You have the suction. So if you know how to stop bleeding, you don't have to use suction, and so you can use easily one hand. So I think that after I don't know how to say it because there's not a number, a precise number of procedures, but I think that after 20 procedures and after you are able to overcome the trouble in the external auditory canal, you can have a very, very fast learning curve. Of course, you have to follow these steps. You cannot perform stapes surgery with the endoscope before performing several procedures on mesotympanic cholesteatoma or tympanoplasty type 1 or even T-tube insertions, because you have to go step by step. It's very, very, very important in my opinion. and also many cadaveric dissections. Is very, very important in this kind of surgery.
Sure. Thank you. Professor Panetti, I think asking this question to you, since you have been working with endoscopic ear surgery as well for such a long time, but do you have anything to add to what Dr. Bonali said?
I agree about learning curve. It's very important to have both technique, microscopic and endoscopic, and change the technique when is necessary, and important to perform both technique. This is my opinion. The endoscopic ear surgery is synergic with the microscopic. In my operating room, always I have the microscope near the endoscope. This is the message, the important message for the young surgeons that begin this surgery. The endoscopic is very nice to see, but microscopic is very, very useful when there is bleeding, when there is some problem. We must change the technique when is necessary. This is the important message.
So your recommendation would be to keep the microscope close to in the OR while they are even performing endoscopic ear surgeries.
Che è importante che abbia entrambi sempre.
Yeah.
Always.
Okay, thank you very much. Dr. Bonali, then we received another question with regard to the Professor Presuti's presentation and the acoustic neuroma. Basically, like, do you use different angled endoscopes in these kind of surgeries? And if so, which length of endoscopes and which diameter do you recommend for this kind of surgery?
Okay, so regarding the length of the endoscopes, it's the same. So we use the same instruments with a 15 centimeters length. Regarding the angled lenses, in this case, it's not so much important because you can also use a 0 degree because the area for you have a straight route to the internal auditory canal. You don't have to go inside some middle ear recesses like retrotympanum or epitympanum, but you have to go to work straight on your cochlea. So you can also use a 0 degree endoscope, and you can also use a 4 millimeter diameter because in this case you have to perform a canalplasty to enlarge your field of view in the external auditory canal. So you can put also a 4 millimeter diameter, and you can work easily also with the 4 millimeters because of the canalplasty.
Okay. All right. Thank you. Another question, for these kind of surgeries, would you recommend, or do you have experience, or do you use a navigation system? Is it necessary at all?
We have the navigation system in our department, but we usually don't use it because we prefer the radiology before and our knowledge of the anatomy, because of course, as I told you before, this is the last part of your training program in endoscopic ear surgery, and you have to know the anatomy very, very well. But the magnification of the structures and the possibility to see directly the medial portion of the tympanic cavity, and so all the anatomical structures, you don't need to have navigation systems, in my opinion. Of course, if you have it and if you want to use it in the first cases, it's possible because it helps you in some difficult steps. But after 3, 4, or 5 cases, you can use you can perform the operation without the navigation. So if you don't have it, it's not a problem. It's not necessary for this surgery, in my opinion.
Okay, perfect. And then the last question is about, again, oh, sorry, Professor Panetti.
No, I just want to say a little thing, but the most important thing is the knowledge of the anatomy and the dissection. I will remember that Dr. Nani is the first that as a utilized the dissection for the endoscopic hair surgery with chips, with animal model. And is very, very important, the training with dissection, also with ovine material. And is important thing, improve this surgery for this innovation. I know that you wrote a book about this. I just want to remember this step. You agree, Marco?
Thank you very much, because you're so kind. Yes, the book will be published, I think, in December, and it's an atlas of dissection on the ovine model for all these steps, from the external auditory canal to the inner ear on the ovine model. And I developed this kind of model because I know that my residents are very happy when they can dissect and they can try these gestures with the endoscope and with the instruments. And this is a very nice model because it's free of charge, and you can dissect many, many specimens and gain experience with the endoscope. And after that, if you perform a course on a cadaveric dissection course with the humans, you are already trained, and so you can focus your attention on other things, not on how to elevate a flap, because you already know how to elevate a flap. So I think that all these models are useful, and I thank you, Professor Panetti, for his.
I remember you that before the lockdown, we are programmed with together the Spiegel a course in Napoli in my hospital, but that then it's impossible to realize.
I'm ready for that.
Okay, thank you.
I'm ready for that. Just to say a funny thing, in my hospital, they call me the shepherd because I always work with the ovine model. So I am well known for this also in my hospital.
We just received another question on the live chat, and in this case is regarding the instruments, and it's addressed to Professor Panetti. Some surgeons, it seems that they may find the instruments that you helped design, that you designed, the Panetti instruments, they find them a little bit too sharp. What would you say? What would you say to those surgeons who find them a little bit too sharp?
Could you repeat the question?
Sure. Some surgeons, they find the Panetti, your instruments, they find them a little bit too sharp. What would you say about to these surgeons who have this question about them being too sharp? I don't know if the right word in Italian is affilati, puntiagudo.
Strumenti sono.
Okay, yeah.
Thanks.
This is an old question. Yeah. No, my project is to perform a delicate maneuvers in the endoscopic ear surgery. It's very the problem is for the second sides and the third and fourth sides because sometimes is a little there is a peak, but after 2-3 times that use this instrument is very tondo, round after a little, because it's very strong. Sometimes, if possible, with diamond burr to change this is a little problem. But in the beginning was so. Then in the next production, I show that the point is round, usually in my new set. I remember so. In the first, no, there is this problem. But after the use 2-3 times, the instrument is
not sharp anymore.
not sharp. But very important that single knife invece is very, very good, sharp.
That's the way it should be, right? That is the way it should be. Yeah.
Yeah.
Okay. Perfect. I think one last question was to Bonali, was addressed to Bonali, and is regarding the to Dr. Bonali, excuse me, and it is about the monitoring intraoperative monitoring system. Would you always, or do you recommend to use this kind of device, an intraoperative monitoring device, every single time in cholesteatomas and neuronomas? Do you always use it?
So regarding neurinoma, yes, we always use the monitoring system because it helps us to find the magnification of the endoscope, of course, but also this helps us to find the facial nerve and to preserve its integrity during the dissection. So for acoustic neuroma, always. Regarding the cholesteatoma, it depends. Because in the majority of the cases, yes, we use the monitoring system because in many cases the facial nerve is surrounded by the cholesteatoma, and so we are not sure about an eventual descent of the fallopian canal, the bony canal, and so we prefer to use it. In some cases, when the radiology, when the radiology shows you that there is no involvement in that area, we also use only our hands, our eyes, and the magnification of the instrument. So it depends, but it's a radiological assessment mainly.
Thank you, Professor Panetti. Do you have?
I use them in cholesteatoma surgery, sometime in the revision of tympanoplasty, when there is soft tissue granulation, descent facial. Only in these cases I use it. I don't perform in ear surgery in my hospital because I have the neurochirurgy. And only in middle ear surgery, I use only in some cases, rarely.
Okay. All right. Well, thanks a lot for answering the questions from the participants. And now I'm going to hand over to my colleague, Matthias. Matthias?
Well, thank you, John. I hope I'm not on mute. No, that works. Yeah, you're absolutely right. Unfortunately, we have to come to an end. We are already far behind schedule, but nevertheless, I'm sure those have been very, very interesting 2.5 hours for all of us. I really enjoyed every minute, but I would also say thank you to the speakers and to your team for taking your time and share all the knowledge about this unique approach. But last but not least, all of this wouldn't have worked if the team wouldn't have done such an excellent job to organize the entire webinar. So thank you into the round for the great collaboration and for that teamwork that really worked out quite well. For the end, for the one that were not able to watch the entire webinar this time, there will be the same exact webinar starting tomorrow at 5 p.m. CET, Central European Time. with the only difference that that time Professor Prasuti will be on board talking about his presentation. So also please stay tuned and in touch with your distributor to learn more about our future webinars that we have in plan. So those are webinars we will provide in the close future. So I wish everybody a great rest of the day or a nice evening. And yeah, please stay safe and healthy and see you next time.
Thank you very much.
You're very good.
Much. Aye.
Bye-bye.
Goodbye.